Okay. All right. So if you have your microphone, whenever I call your name, go ahead and say here. Let me know that you're paying attention to the class. First one on the list is
Here.
okay. We have Caitlin next.
Here and Jaren's here.
Jaren's here. Okay. What's next?
Huh? Was he next?
Yeah. Well, I've got Jaren and then Chuck.
You're here.
Sorry.
Chuck's on the web, so he may not be able to answer. I've seen him type in there that he's here. Next is Danny.
Here.
Jeffrey.
Chuck's here.
All right, so that's both of you. Casey.
I'm here. Oh my God.
Next we have Crystal.
Dang work.
It's working.
Okay.
Next, Crystal, are you there?
I'm here.
Lisa.
Yes, I'm here.
Michael Sexton.
What's up?
All right, both Van Winkles.
Here.
Okay. Mitchell
Here.
and Steven.
Here.
Okay, and then we'll catch Krishna whenever he gets on here. So I'm going to go ahead and mute all of you guys. All right. So the chapter we're going to go over today is pharmacology. Realistically, should be a fairly quick chapter. Like I said before, if we get through it in a decent amount of time, we can continue on, or we'll cut it short for the night. Can y'all see that screen?
Yes.
Yeah, if you need to unmute yourself, just click the unmute button. But all right. So by definition,
Yes.
pharmacology is the study of medicine. Okay. What we're going to end up doing is applying the fundamental knowledge of medications that you may end up either assisting the patient with taking or giving them themselves. Two main principles from it, obviously medication safety. We want to make sure we're giving the right medication, given the correct dose, making sure they don't have any allergies to it, and then knowing which different kinds of medications there are for an emergency. Most often the ones we end up using, albuterol, nitro, and then epinephrine or EpiPens. Those are the three most common ones that you guys will probably end up messing with, either on clinicals or whenever you go work as an EMT. A couple different ways to administer them. Self-administered, obviously, is you giving it to yourself. Peer-administered would be like if we're on a truck and one of us has to give the other one a medication. That'd be like if we had some kind of allergic reaction to something and we gave our partner an EpiPen. Either assisting or administering medication to patient is pretty self-explanatory. If they already have an inhaler, we can help them take it, or if they have their own nitro, we'll help them take it. If not, we use our medication, whether it's on the ambulance or on the engine. Important things to know for your medications, obviously the names of them. Can't really give it anything if you don't know what it's called. knowing the effects, what it's going to do to the body, what it's going to do to their vital signs, how it's supposed to work, and then the actual way it's going to work. We can say, oh, well, it's going to make them breathe better, but how? How is it going to make them breathe better? Well, albuterol is going to open up the bronchioles. It's going to let them breathe easier by dilating that. Indications is why you're going to give it. Okay, well, why do we give albuterol? They're having trouble breathing, they're wheezing. And then contraindications, since it's got that contra, we learned a couple of those way back when we started. Contraindications are things we should not be giving this for. That would be like if they're breathing just fine normally, we're obviously not going to give albuterol. Couple things to consider: complications. What can happen when we do give this? Any adverse reactions to it? You know, if you give albuterol, their heart rate's going to go up. What if it goes up too high? What if they're allergic and we didn't know about it? What can that do to them? Routes of administration, we'll go over a couple of those here in a little bit, but obviously two of the main ones would be either through the mouth or through an IV. Side effects. I think we've all dealt with side effects of medications before. They're usually a long list that includes just about every kind of thing you can think of. So interactions means interactions with other medications. Okay, so a lot of times when we give medications on the truck, they work with other ones in tandem. They can make things better, they can make things worse, they can increase the effect of one or increase the effect of another. Best example was we used to carry a pain reliever, and if you gave it with either Zofran, which is for nausea, or Phenergan, which is for nausea as well, it would make that pain medication work better. So that's where interactions comes in. And then obviously dosages for the medications. We need to know how much to give them. Pretty much everything is weight based. Obviously, medications are an important intervention. Okay, that includes oxygen. Oxygen is classed as a medication. Okay, you actually have to have a prescription for it. But all those are extremely important. They can provide pain relief. They can make conditions better. They can improve breathing. They can keep somebody alive. You name it. The big thing is if you don't do it correctly or safely, we get into those adverse reactions. We could end up actually killing these people if we give them the wrong medication. So here in a little bit, it'll explain the 6 R's for medications, and that's where that comes in. We'll make sure that it's the right dose, the right name, the right patient, the right route, because we do not want to do the wrong thing for these people. So, as an EMT, you're going to obviously administer medications when it's called for. If the patients have their own medications, you're going to self-administer or assist them with it. A lot of times when we tell these folks, hey, do you have nitro? Oh yeah, I have nitro in the house in the drawer. Okay, well, why don't you go ahead and take one? As long as we watch them take that and they do it appropriately, no harm done. Asking about medication use, that kind of goes back into our assessments. We talked about getting a sample history. Allergies and medications is a big part of that. And obviously reporting this information to the hospital when we get there. If we gave them medication, we for sure need to tell them, hey, we went ahead and gave them 2 doses of albuterol. That way they're ahead of the game. They know exactly what we've done. That way they can keep that treatment plan continuing. Like we said, pharmacology is science and study of drugs. Definition of medication is something used to prevent or treat diseases or to relieve pain. Down there it says pharmacodynamics is how it actually works inside the body. There's a couple different words for you. So agonist is where that medication binds to those receptors and causes an effect. The opposite of that is that antagonist. The antagonist still binds to those receptors, but it blocks anything else from happening. So best example for that is Narcan. Okay, when we have somebody who does opioids, those opioids bind to those receptor sites, cause that effect, cause them to slow down their breathing, cause them to stop breathing eventually. The Narcan binds to those same receptors and keeps that medication from reacting. And then dose is obviously how much it's going to be given. And that's weight, age, and how much of an effect we want to have. And all those are different. Those are based on your medical director, whatever protocols are set down. The action of medications is also called the therapeutic effect. That's what we're trying to get to. That's where we say, okay, we're giving this medication to get this certain reaction out of it. Like we said just a second ago, indications, why we're giving this medication in the first place. A little bit more about contraindications. It's kind of the no-goes for medication, why we're not going to give it. Absolute contraindications are dead stop, do not give it. This will cause some obvious harm to the patient. Relative contraindications, they could be bad, but at the same time, giving that medication could work, and you have to weigh risk versus reward. Side effects, we talked about those. Things we obviously don't want to happen. Unintended or things that are undesirable, they're not going to necessarily cause a lot of problems. That'd be like if you took ibuprofen for a headache and it made you drowsy. Probably not going to happen, but even if it does, it's not necessarily harmful. Untoward effects are the ones that are possibly harmful to the patient. That would be like when you take, your Tylenol 3 and it slows your breathing down. Or you take a fentanyl patch and put it on and it drops your blood pressure, drops your respiratory rate. Those are untoward effects. So when we talk about medications, they usually have a couple different names. Okay, like generic names, a whole lot easier. They're lowercase. We know most of those ones, like ibuprofen. But brand names are from the actual manufacturers. So Tylenol makes ibuprofen, but they're going to call it Tylenol. Tylenol PM, Tylenol extra strength. Same medication, different doses, but it's a brand. So just be aware that when you go in and talk to these folks, they may say, oh, well, I take Lasix. Well, Lasix is a brand name. What's the generic for that? Well, it's furosemide. So just be aware that there are plenty of manufacturers out there. You will probably encounter all kinds. You'll probably see some that I haven't seen before. You'll see some names that you have no idea what that is. That's okay. Medications change constantly. You may have to look it up. So prescriptions, obviously, those are ones where you have to go to a doctor, get a prescription for it. Like I said, oxygen is one of those. It does require a prescription. Anything, a narcotic for sure, as long as you're getting it legally, has to come from a doctor. You have to have a prescription. Over-the-counter medications, like we just talked about, ibuprofen, that's an over-the-counter. You can get it without having to see a doctor. Other types, obviously, recreational drugs, heroin, marijuana, cocaine, you name it. I'm sure there's some out there that I don't even know about. Herbal remedies are considered medications. That could be your essential oils, I don't know. The way I think of it is hippie medication, stuff hippies used to use. That's probably not very PC, but things like that. Enhancement drugs, steroids, and then vitamin supplements, your B12s, your vitamin C. Anything that a patient can take that can have some kind of reaction in the body is considered a medication. At the same time, they may not understand that those vitamins are medications that they need to tell you about. So just when you're getting a sample history, ask them, okay, are you taking any prescriptions from any of your doctors? Are you taking anything over the counter? If they're honest with you, are you taking any recreational drugs? Do you have anything else that you take to help you with this problem? So this is one of those bars for the right medications we'll talk about in a minute. Different routes. We got two main things right there. Enteral medications, those work through the digestive system. So the digestive system works through your mouth. Those will be your pills, your liquids, think cough syrup, that kind of stuff. Parenteral medications, they have to get in the body through some other means. Main thing with those, think your IVs. That medication that we push through an IV has to get in there through the IV. It had to have some kind of adjunct for us to make it work. Think about it like a rated R movie or something. Kids can't go see that movie without their parents. Right? A dumb little idea, but if you remember it that way, and it works. Absorption, obviously, is anything that can be put on the body tissues and absorbed through their bloodstream. Think of your topical stuff. Fentanyl patches can be absorbed through the skin. And then down there, you've got your abbreviations. So PO is obviously per oral, by mouth. PR is the opposite direction, through the rectum. Just remember that if they're taking medications that way, it's usually a bit stronger of a reaction because it goes straight to the digestive system. It doesn't have to go through the stomach and be worked through there. So a lot of times those medications that are given regularly work just as well as things given IV. Like we just said, IV, it's obviously into the vein. Intraosseous is through the bone. So I'm sure y'all have seen when we go on cardiac arrest and we drill into the bone, give medications that way. Subcutaneous is just underneath the skin. A lot of those will be almost like shots, but we get into that small little, almost fatty layer right before the muscle. And then your IM shots or your intramuscular, that's like your flu shot. I think of some other ones. A steroid shot, anything you get in those large muscles. And that's mainly because the muscles are extremely vascular. They have a stable, good blood flow to them. So that medication is dispersed fairly quick.
Sean, the drugs that you put like in your mouth and you have them dissolved under your tongue, like nitro and stuff, would those be considered oral or would those be considered an absorption?
So we're fixing to get to that one. So a couple other ones. So we'll go ahead and address that one. Nitro tabs that go underneath your tongue are considered sublingual. Okay, they'll end up dissolving. So it's being absorbed, but since it's specifically under the tongue, it's given its own, I guess identifier would be a good word for it. Inhalation, it's like your albuterol for asthma. We inhale that stuff into our lungs and then it gets into the bloodstream that way. Transcutaneous is another kind of absorption. It's through the skin. That'd be your a lot of your patches, your transdermal patches. And then intranasals right up the nose. Most time, especially with us, that's where our Narcan goes. Narcan's used through the nose. All right. So if you can see that, that's just what we've just been talking about is the different routes, how quickly they work. Obviously, by mouth is a little bit slower. It has to go through the digestive system. Sublingual and rectum are a lot quicker. Obviously, your IVs and your IOs are going to be a whole lot faster, which is why most of our medication on the ambulance is IV. Obviously, the form of the medication does dictate which way it's going to go. If it's a pill, it's obviously going to go either in the mouth or through the rectum. If it's a liquid, it's either going to go through your mouth or it's going to go IV, one or the other. Just make sure that you know which one it's supposed to do. Okay, you don't want to give an IV medication through somebody's mouth. Excuse me. A lot of those are up to the manufacturer themselves. They can make them however they want. There's all kinds of rules and regulations for how that goes. Just remember that the timing for how well that medication is going to release and work for that person is dependent on which route it's going. That may or may not be a test question. All right, so here's a couple different forms of medications that you'll encounter. Tablets and capsules are obviously the main ones. That's stuff we can get over the counter. Solutions to suspensions, think of your cough syrup. Meter dose inhalers, I think we're all fairly familiar with, mainly used for asthma. And albuterol, topical medications. That can be things for burn treatment as well. If you got that Silvadine, that's a topical medication. Transcutaneous medications, med patches, fentanyl patches, gels. I haven't encountered too many of those. And then your gases, which would be, again, your albuterol. You could have a nebulizer at the house. Does all that make sense so far? Okay. Right. Like I said, capsules are shells filled with powdered liquid medication. Most time they got other materials in there with that medication that's compressed down. That's usually to keep the medication viable for a longer amount of time. All of these have to be digested so that that shell can be broken up and the medication can get into your system and start working. So solutions are that liquid mixture of substances. These ones you have to shake a little bit. But once you get them mixed in, these ones will not separate afterwards. A lot of these ones are going to end up being given as IV. You can think of Solumedrol as a medication. You can think anytime we put like epi into a normal saline bag to do an epinephrine drip, things like that. And then suspensions are stuff that doesn't dissolve well. Those are the ones that you have to really shake. Most of those come from your physicians. Because if you let them sit there for a while, eventually they'll separate and you'll have that cleared. You know, there'll be one medication colored down on the bottom and there'll be one on the top. I think everybody knows what that looks like. It's one of your inhalers. Aerosolizes those droplets so that they can be inhaled down into the lungs. Good thing is they deliver the same amount of medication every time you pump it. Downside is some people like to pump it multiple times. So just be aware if somebody says, well, I pumped it 4 or 5 times because I didn't think I got enough, they've actually had 4 or 5 normal doses each time. Like I said, topicals, lotions, creams, ointment. Like I said, Silvanine's one of those. Neosporin's a good one. It's an ointment. I'm sure we've all used that before. All right. So these are those patches that I was talking about. Nitro paste, fentanyl patches. They get placed on the skin, and then it kind of diffuses through those. Sorry, computer's trying to restart. But it'll end up diffusing through and it'll have a system-wide effect. Like fentanyl patches, once they put them on, they have that pain relief. Main thing with those is, if, case in point, fentanyl patches, if we think there's something wrong with them, if we think they've had too much of something, always look for the stuff on patients. Nothing sucks worse than having to bag this patient, not figuring out what's wrong, get them to the hospital, they cut the shirt off, and they've got 2 or 3 fentanyl patches on their back. So always double check for patches. Real important point right there. If you touch that medication with an ungloved hand or it gets on your skin, your body's going to absorb it. So just be extremely careful. All right. Gels, oral glucose. Yeah, that's a good one. Sure, we've all seen oral glucose before. Not much to say about those. Again, gases for inhalation, 2 main ones, albuterol for nebulizers, and then oxygen, probably the biggest, most important gas we have for inhalation, right? All right, we're getting into those 6 rights that we were talking about. So, what do you? Let's go ahead and have a question. That way, it's not just me talking this entire time. So, take a guess as to what a few of the 6 rights are.
Right time, right patient. I don't know the rest. Right time, right patient, right medication.
Right dose.
Right dose.
Yeah.
Right route.
Right out.
Right time.
Yeah, I was gonna say right medication.
And documentation.
Hey.
Document.
Documentation, yeah. So documentation is a little bit newer. I remember it being the 5 R's, but documentation is extremely important. So obviously, right patient, we want to know that this is the actual patient we're supposed to be giving this medication to. Most of the time, if we're giving our own medication to the patient, we already know, yes, this is our patient. But if they tell you, well, I have my own nitro, is it actually theirs? Make sure you check the bottle with their name. Is that their name? If it is, great. If not, we may want to wait and not give them that medication. Same time, make sure it is the right medication. That's 2 different ways. Make sure the patient hasn't put any other medication in that thing, or if they have their little pill, their Monday through Friday weekly pill planner, make sure you're pulling out the right medication. If it's on the ambulance or it's on the truck, if you're doing clinicals, make sure that you're looking at our vials and make sure it's the correct name and confirm it twice. So a lot of times we'll get in there and if it's a stressful situation and say, hey, I need you to get the Solumedrol out. And you pull out a medication that has an S on it. Well, is it Solumedrol or is it something else? So make sure you pull it out and say, okay, well, this is Solumedrol. Show it to your partner. Say, is this correct? Yes, it's correct. That's 2 people. That's checking twice. Right dose. Granted, if it's their medication, you may not know what their dose is besides what's labeled on the bottle. If the bottle says take 2 as needed, okay, they can take 2. With us, it's whatever the protocols set out for. A lot of times, if that's weight based, if it's 1 milligram per kilogram and the person weighs 150 kilos, then, okay, I'm going to give 150. Draw it up. Hey, this is 150, right? Yes, it's 150. Right route, that goes back to figuring out which one is which direction it's going to go. Is it going to go in the mouth? Is it going to go rectally? Are you going to give it through IV? Just make sure you confirm that that's the correct way to give medication. Right time. Time is always important, especially when we're talking about how long it takes for something to work. Especially going up to the hospital. We give the medication 5 minutes before we get there, and we tell them, oh, yeah, we gave it, at the start of the call. Well, no, we didn't. They may give that medication again, thinking it's already been through their system, and now we've just overdosed them on whatever it may be. So always make sure you write down the appropriate times. And then documentation is with all of that stuff. We want to make sure that we put it down in writing, communication with the hospital, that we did all this stuff the correct way. Because again, if you didn't document it, it didn't happen. So make sure you've got the patient's name spelled right in your documentation, whatever, if that's on the computer or if it's a paper form. Make sure you write down how much you gave them, how you gave it to them, what time, whether it worked or not, or what happened to them is right after you gave it to them. Does all that make sense? Kind of beating you over the head with a bunch of it. All right. Go for about 15 more minutes and we'll take a break. So a couple different medications that you may end up using. Again, all this is dependent on the medical direction, what they're comfortable with their crews being able to give. Obviously, oxygen is probably going to be a mainstay for everybody. Oral glucose, activated charcoal, I know we don't carry. It can be used for overdoses, trying to absorb some of that medication in the stomach. Aspirin, a lot of times for chest pains. And then your epi. Epi's used for just about everything. You got your cardiac arrest, you've got allergic reactions, low blood pressure, you name it. Again, we talked about these before, the peer assisted administration, patient assisted, and EMT administered. So some of them we'll give ourselves, other ones we can have the patient give it. Or if they've got, a family member there that takes care of them who normally gives them medication, let them help. Do you normally give this medication to him? Yeah, well, I give him whenever he has chest pain. Okay, we'll go ahead and give it to him while we're getting vital signs. Again, all that's determined by your medical control and what protocols you have. Okay, some of that medication may not be in trucks that you ride out on. Like I said, activated charcoal, we don't carry. Carry everything else. So just be aware, a good thing to always ask, whether you're on clinicals, whether you're working for another system, or genuinely anywhere, is okay, well, what do we carry? What are we allowed to give? Just talked about that. All right. Oral medications. Good thing about them is they're easy to get a hold of. Okay. Like I said, most of them you can get from over the counter or a prescription, but they're easy. You can pull the cap off, put it in your mouth, swallow it, or chew it up. It's a good comfort level. It's easy. You tell these people, okay, well, instead of stabbing you, with a needle, poking you, just here, swallow this. Downside to them, though, is like we said, they have to work through your digestive system. They have to get into the digestive tract through the stomach, which delays that effect we're trying to get. At the same time, if you ate a really heavy meal right before your pain started or something happened, that can affect how quickly that's absorbed. That's why, for one part of why they don't want you having anything to eat before major surgeries or anything like that, so that medication will work that much faster. Then, so you don't throw up and aspirate when they try to put a tube in your throat. Main thing you need to make sure is that they can follow directions and that they can swallow. There's no point in putting a pill in somebody's mouth if they're not going to be able to swallow it. Okay, we could cause them to aspirate, we could cause them to choke. So make sure they can follow your commands and that they can swallow. Those are two different things. They may be able to follow commands, but they may not be able to swallow. Or you could look at them and they're swallowing like crazy, but they're not able to follow your commands. Got to have both of them. There's that activated charcoal. Like I said, it reduces the amount of medication that gets absorbed. Usually comes suspended in another medication. It's given by mouth. Again, same thing with anything that you're going to give orally, is you do not want to give it to anybody who has some kind of altered mental status. If they're not able to follow commands, don't shove anything in their mouth. Has anybody ever seen activated charcoal given? It's not pleasant. Oral glucose, I'm sure we've all seen a little bit of that. This is another one. If you've seen it, it's incredibly sticky. It's thick. A lot of times, these people are able to follow some commands and swallow. But if you're not sure, or it looks like they're not going to be able to keep that airway open, don't give it. Okay. Main thing with any kind of oral medication is you always want to make sure that we're not going to compromise their airway or cause them to aspirate. So, when in doubt, err on the side of caution and don't give it. All right. Aspirin, I'm sure we've all had some aspirin at some point in our life. It's a good fever reducer, takes care of the pain, reduces inflammation. Also inhibits platelet buildup. It's real great for during heart attacks. That's why we give aspirin on anybody that has chest pain. Keeps them from building up clots. Some downsides to it, these contraindications, like we said, this is stuff that we don't want to give them this medication. If they have an obvious hypersensitivity to it, if it works way too good on them, we probably don't want to mess with it. Liver damage, bleeding disorders, or asthma. That's because, again, we're reducing that inflammation. So if they have asthma, we could make that worse. Bleeding disorders, a lot of times we'll ask about stomach ulcers because we're reducing that platelet buildup. So they're not going to be able to clot properly. If they already have some kind of bleeding problem, that's going to be made worse. And then the aspirin is usually fairly hard on the liver. If they've already got liver issues, we may want to hold off on it. Liver may not be able to process that medication.
Really?
What?
Congrats, your dad.
Hmm?
Sorry.
Oh, okay. I thought you were yelling at me.
Oh, the cat's turning on my mic.
Definitely don't give aspirin to kids. They should not need it. Most of the time when you're giving kids medication for fever, it's probably going to be Tylenol, which is ibuprofen, or Motrin. All right, so sublingual, this is the one that goes underneath the tongue. Biggest one we have for that is nitro. It's easy to tell them what to do. Here, put this underneath your tongue, let it dissolve. That's it, done deal. It gets absorbed fairly quickly. Most of the time, within 30 seconds, it's already working. Downside is if they're not extremely aware, you may have to keep an eye on their airway. They could, depending on how big this pill is or their airway, they could flip it up and aspirate it. They could choke from it. It's happened before. Definitely not going to give it to people who are unconscious. They can't stick it underneath there. We can't lift their tongue up and hold it underneath there either. And if they're obviously going to be combative or uncooperative, we're not going to mess with it. You're not going to give something to somebody that they can turn around and either A, try and choke on it on purpose, or they're going to try and spit it out at you. There it is, nitroglycerin. Either comes in pill form or it can come in as a spray. It's designed to relieve that pain in your chest from spasms from the vessels. Nitro tends to open up all the blood vessels, relaxes those muscles. The downside is it also relaxes the veins everywhere else. So people's blood pressure tends to go down when you give this. Main thing to do, check their blood pressure. Depending on your protocols, if their blood pressure is a certain number, you won't give them this medication, even if it would help them. At the same time, you need to make sure that you are authorized to give it. Again, that goes back to whatever protocols are set down by either the state or by whatever medical direction you have. At the same time, if you do have to ask about ED medications, okay? And people get embarrassed. They may not want to be honest with you, but you do have to ask, hey, do you take any sexual enhancement drugs? Oh, no, I never do that. Well, I'm not worried about your life, but if you take those medications, a lot of times those medications drop blood pressure as well. If we give somebody that medication, the nitro, and they've been taking that, we could cause a fatal drop in blood pressure. So if anybody has any fear of asking those questions, they're going to have to get over it. Okay, we have to make sure we ask about all types. At the same time, it's going to cause a headache, usually by the second or third one. Again, that falls back on we're dilating all the vessels. So if we're dilating vessels, we're dilating ones in the brain too. That's where the headache comes from. So most of the time you'll encounter it as the tablet form. It comes in a little tiny bottle. It's dark. It needs to be kept in a dark area. Sunlight degrades it. You'll take one out, have them open their mouth, stick their tongue out, and you place it in there. They may feel kind of a tingling, burning sensation in it. That's normal. If it's a spray, all you do is one spray underneath the tongue. You can put it on the tongue as well, but only one spray. Okay, so it's either one tablet, one spray. Don't sit there and pump it like times thinking you got to get a good coating.
Sean,
Yes.
my understanding of nitro pills, if they've been open for more than 30 days, their effectiveness is not as good as when they first opened that bottle.
Yeah. So and another reason why they're coated in that dark coating for their vial. Once they're opened, once they're exposed to any sunlight, anything kind of degrades that effectiveness. And that's not saying that if they say, oh, well, this is 60 days old, I haven't been able to go get the medication. No, still use it. Just be aware that it may not work as well, if at all. But most of the time, when we give this medication, take a blood pressure before. Then once you give it, wait about 5 minutes. Take another blood pressure. give another dose. We give doses between 5 minutes. Always check blood pressure before you give another one. That way,
So,
go ahead.
oh, I'm sorry.
No,
So at that point, would we give our medication if theirs is not working?
we can if we're authorized to and if we have it, which I mean we will on our trucks. But yeah, if it doesn't seem to work, if their blood pressure hasn't changed, if they have no relief, go ahead and give ours a shot. Just make sure you take that blood pressure before you give it. That way you know beforehand. You don't want to sit there and say, okay, well, I'm going to go ahead and give you another one, and then forget to take your blood pressure, take it afterwards, and now they're down to 70/30 for a blood pressure. At the same time, wear gloves, especially if you're giving the spray. I know it's going sublingual. It absorbs way faster that way, but it always has the potential to absorb through your skin. And then just make sure you know your local protocols. Like I said, ours, we give nitro. We give nitro every 5 minutes as long as their blood pressure stays above 110 systolic. So that could be different for any service. It all just depends on what that medical director is comfortable with. All right, that's a good breaking point. We'll take a break for about 5-10 minutes. Let me go ahead and pause.
I believe in you, Sean.
We'll see. All right, so we've got 15 in here now. Cruz, Daniel, I think y'all were the 2 additions. I think everybody else has been here since the beginning. All right, so we talked about sublingual oral medications, intramuscular. Good thing for these, the muscles are very vascular. It's very easy to get medications in here without using veins. We don't have to sit there and search. We can just find that muscle, put the needle in, medication delivered. The downside of it is that needle. Most people aren't really thrilled about having needles poke them. There's a little bit of pain involved, depending on who's given the medication. And then, obviously, if they have some adverse fear or phobia of needles, that may be a problem. Main thing with that is try and talk to them about it. Say, this is going to be a slight pinch. Don't lie to them. Don't say, oh, this isn't going to hurt at all, because we know that's a load of junk. Just be honest. Say it's going to hurt for a second, but this medication should help you. We're only doing this to help you. We're not trying to hurt you. Because we're trying to treat these patients, not just their physical problems, but any kind of mental, emotional issues that they're having as well. And usually when we show up, that becomes a pretty emotional issue. Nobody likes seeing us. So main IM medication is going to be your epinephrine, used for, like I said, cardiac arrests and allergic reactions. Epinephrine is produced by the body itself. It's called adrenaline. That's how our fight or flight response works. So, when we called you guys out the first day to get in groups and talk to each other, and you said, oh crap, I want to get the hell out of here, your epinephrine kicked in. It is sympathomimetic. What that means is it simulates the sympathetic nervous system. It stimulates that. So it's causing a reaction and effect for that. So that's where all the vessels will constrict, reduce that inflammation. Obviously going to increase your heart rate a little bit when you give this. Hence why adrenaline and epinephrine are a part of the fight or flight response. Constricts those blood vessels, kind of increases the blood pressure a little bit as well. Obviously, with patients with hypertension already, we want to be cautious with it. If they have extremely high blood pressure, if they're sitting at 220 systolic, probably not a good idea to give that to them unless it's absolutely needed. If they're hypothermic, their vessels are already going to be constricted anyway as well. If they're having a heart attack, probably not good to give that either. They're already having issues with getting enough oxygen delivered to their heart. Constricting those vessels is going to make it even worse. And then again, if they're wheezing already, we're just going to constrict those passages again. Like it says right there, we can either give it IM by drawing it up in a medication and using a needle, or it can be used as an auto-injector, which is the EpiPens. Most of the time, those EpiPens are used when somebody's having anaphylaxis, where they're having a major allergic reaction. We talked about it a couple times before with immediate life threats. That's a big one. So if they're having that massive wheezing, can't breathe, changing colors, and somebody says, they ate this and they're allergic to it, go ahead and give them some Epi. They're going to need it. So by definition, an allergic reaction is some kind of foreign body reaction. Your body reacts to that foreign object or allergen. It causes a histamine release. So that's where everything starts swelling out. The vessels are all dilating real fast. That's where everything swells up in your throat because it's all dilating. Epinephrine is an antihistamine, so it's trying to reverse that effect. And again, it's given through an auto-injector. Narcan's another one, or naloxone. Naloxone is the generic name. Narcan is the brand. But that can be given IM as well. It's used to reverse any kind of opioid overdose, whether that's fentanyl, morphine, heroin. Most things to look for when you're going to give this is you're looking for pinpoint pupils where their central nervous system is depressed, their respiratory system has taken a nosedive, they're not breathing at all, or they're breathing incredibly slow, blood pressure may have dropped, heart rate slowing down. Those are all real good indicators for giving this medication. At the same time, just be aware that once you give it, it's very fast acting and it's short. It doesn't last very long in the first place. So while it may wake them up, they may not stay that way for long. We've had a couple problems with system-wide of giving Narcan at times, people waking up and saying, well, okay, I'm good. I don't want to go to the hospital. You took care of the problem. They'll refuse because they're alert and oriented and they can. And then 30 minutes to 45 minutes later, somebody else is running an emergency on them because they've stopped breathing again. So just be aware that these people need to be looked at if we're giving these medications. At the same time, it's going to cause withdrawal symptoms. If any of you guys have been on scene with us when we've given Narcan to somebody, they usually get really pissed off. If it's old grandma who accidentally took an extra pill, not a big deal. She's probably not going to get mad. But if it's somebody who spent a lot of money trying to get that heroin, they're not going to be too pleased that you just blew their $350 for them. So consider your safety when you're doing that. If you can manage them without giving it, great. But if their heart rate's in the toilet, if their blood pressure's dropped and they can't breathe, or you're having to beg for them, it's definitely something to consider giving. Same thing with intranasal. Narcan can be given that way too. It's a whole lot easier. You don't have to stab anybody with a needle. You don't run the risk of hurting yourself. You just pretty much close one nostril, place that thing in there, and squeeze whatever amount of medication you're going to put in their nose. Most of the time, you split it half between one nostril and half between the other. So with our Narcan, it's 1 milliliter of medication. So you would do half in one nostril and half in the other. So just don't go slamming an entire thing of medication up one side. So inhalation medications, a lot of times with these, like we said, it's albuterol nebulizers, it's oxygen. Good thing about oxygen is we all need it. We have to have it. If we don't, we're dead. Most of the time, we're going to give it through a non-rebreather mask set at 15 liters. Most of the time, it's the preferred method for one, especially now. Keeps everything closed. They're not spreading any virus or any disease on you. They're not breathing on you. Nasal cannulas are good for those who can't have that mask on them, who freak out and say, oh, I can't have anything on my face. Okay, let's put on a nasal cannula on your nose. You just have to breathe in. Nasal cannulas go up to manufacturer maximum probably of 6. Protocol wise for us when you're on clinicals is 4. Same thing with inhalation, those metered dose inhalers and nebulizers, they take that medication because albuterol doesn't come in just like a gas that we have to collect and suck in and put in this bottle. It comes as a liquid. What this does is shoots that oxygen through that tubing there and aerosolizes it. It turns all that liquid into a mist. That way it can be inhaled and absorbed down in your lungs. Good thing about it is it works fast. It's very easy to get access to and it's portable. We can pretty much, you guys have seen it, we can pretty much give albuterol treatments just about anywhere. The only kind of downside to that is if they're going to actually hold on to it or not. They have to be able to pay attention. They have to be alert enough to follow commands and to be able to breathe in that medication. Same time, some of these folks may have their own inhaler. That's great. We can use that. If they have a spacer, that's even better. So that spacer, what it does is it creates just a little chamber for that medication to aerosolize so they can actually pull it into their lungs. So if you can see that picture, what it does is, you press down on the top part, it makes that sound, pushes the medication through, and then they breathe in. That way it sucks all that medication all the way down. Personally wish we had all of those on the trucks. That would be really, really helpful. Same time, it's really good with kids because most of the time when you tell kids, okay, when I press down, I want you to suck in, they're just going to go, as soon as you press, go, and that's it. They're not going to really try and hold that medication in. If we use a spacer and tell them, okay, I'm going to press down, I want you to breathe in as hard as you can, pull all that air in there, they might suck down a little bit more. All right. Nebulizers, that's what we just talked about. You guys have seen ours, or you may even have some at home. They do take a little bit longer than inhalers to give that medication. At the same time, they're usually more effective. Lasts a little bit longer. Doesn't force them to take that deep breath, because half the time with, especially with asthma or these COPD patients, they may not be able to take that deeper breath. But with that normal breathing, they may be able to get in enough through a nebulizer. Good thing is with the CPAP devices, you can put albuterol into the chamber and have it nebulize at the same time as giving that positive pressure. I have not seen anybody give albuterol during bag mask ventilation. That's kind of interesting. That's not saying it can't happen. I just haven't ever seen it before. So again, going over a couple of these, patient use or self-administered. those rescue inhalers, usually for asthma attacks. That's where that thing gets in there and takes care of those spasms extremely fast. A lot of times you'll see kids at school will have them, especially if they're outside playing or anything like that. They'll have sports-induced asthma. That's what I was looking for. Most time, if they're having a actual asthma attack, inhalers are probably going to be the only thing that works. Those nebulizers will take too long and they won't be able to breathe as well through that. So that goes back to the fast acting and short acting. All right. So when you're talking about patient medications, that goes back to that sample history we talked about, signs and symptoms, allergies, medications, past medical history, last oral intake, and then events leading up to the situation. Doing that assessment helps you figure out what kind of medications they're taking, whether or not they actually know. A lot of times some folks will forget. They'll say, well, what medications do you take? Well, I take a blood pressure medication. And then they forget that they also take something for diabetes. But they tell you that they have a history of diabetes. You may be able to figure out, okay, there might be something to that. That helps figure out what kind of treatment path we're going to take. And at the same time, it's extremely helpful when we get to the hospital and give them that information. That way they can give more definitive end-stage care for that patient. We may not have anything necessarily to treat a certain problem they have, but the hospital will. So if we can get them that information sooner than right when we're dropping the patient off, the better. So medication errors. It does happen, unfortunately. Sometimes you get the wrong medication or you give too much of the medication. When we do that, it can lead to consequences for the patient. It could hurt them. It could make it worse. It could potentially prove fatal. Good thing is most time we can eliminate errors just by making sure we do those 6 R's that we were talking about earlier. At the same time, if we know what may happen to those folks if we give them the wrong medication, or what that medication can do to somebody that doesn't need it, may make us a little bit more cautious with it. At the same time, ensuring the environment doesn't contribute to errors. That just means some of these scenes we get to are chaotic, whether it's a cardiac arrest, whether they're circling the drain, or just a whole lot of stuff is going on. We have to make sure that we're trying as best as we can to stay, calm and collected, not letting anything frazzle us, because that's when mistakes get made. A good thing to always think of is it's their emergency, not ours. That doesn't mean we're not going to treat it serious, but we need to make sure that we're not panicking like they are, because most time if folks see you panic, they're going to panic even worse. So just try and stay as calm as you can. Again, the 6 R's, confirming with your partner, double checking everything. I sound like a broken record when I'm out there. I will double check and triple check and make sure that I'm 100% positive that this medication is the one that I need to give. Does that all make sense? Why we want to make sure we give the right medications?
Yes.
And at the same time, you can make yourself a little cheat sheet. If you need to, take a pad or pen and paper, tape a piece to your leg that says, right name, right dose, right medication, right route, right time, right documentation. If you need that right there next to you, then that's, by all means, that is perfectly fine. If it keeps you from doing harm to the patient, nothing is off the table. Good thing to always do, though, is if you're fixing to give something, ask yourself or ask your partner, why am I doing this? Granted, you may not want to sit there and ask your partner outright the first time, why am I doing this? Because if they're the EMT or if they're fairly new, they may look at you like, oh my gosh, he doesn't know what he's doing. But double check with yourself. Why am I giving this medication? Because they're having an allergic reaction and I need to reduce that. There's your indication for it. But if all else fails and you did give a medication wrong, give the right care. You know, if it caused a reaction, treat the reaction. Continue taking care of the patient. Obviously, as soon as you realize it, notify medical control. Whether that's calling usually that would be calling the facility you're going to, letting them know, hey, you know, we were supposed to give epinephrine. I gave, you know, sodium medrol instead. It did this. Do you have anything that I can do? Follow your protocols for whatever happens after that. Treat the patient accordingly. Document it. Don't ever lie about it. Okay? If you gave a medication wrong, own up to it. Document it on your paperwork. Medication was given in error. Facility was notified. Patient was managed appropriately afterwards. Don't ever lie, because if something happens to that patient, if they end up dying from it and you never documented it, but they find out, whether it's from a comment you made up there or if it's recorded on the radio that you gave that, it's going to be on you. You can end up having your patch taken away. You can face extreme legal consequences from it. So once you document all that appropriately, afterwards, you know, for one, talk to your partner, figure out why it happened. Maybe there's something you missed. Maybe, you know, they had said, hey, wait, you don't want to give that medication and you didn't hear them. But at the same time, talk to your supervisor, your medical director, let them know, hey, had a medication error. What do I need to do per the company, per the service to document this and get it taken care of? That way they know as well. The more people, the more management that you have on your side, being upfront and honest with it, the better. Okay. Yeah. Let's review a little bit of this stuff. So pharmacology is defined as what?
B.
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 Team Nasty.
Ew.
We haven't seen that team in a while, huh?
B.
So yeah, so B, yeah, pharmacology, just study and science of medications. All right. So which of the following statements regarding medications is false?
C.
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 What is D for 500, Sean?
I'm sorry to tell you,
Hippie drugs.
it's C. So take a look at it. EMTs should ask about herbal remedies. Remember we talked about that a little bit, whether or not they're viable medications that we believe work. It could have some kind of reaction that we do. So that's technically one that we do need to do. But over-the-counter drugs don't have to be prescribed by a physician. Those are ones we can buy just outright. We don't have to go to the doctor for. That'd be your ibuprofen, your Tylenol, your NyQuil, stuff like that. All right. So which of the following routes of medication administration has the fastest effect out of all those?
B.
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 Yeah. IV is going to be the quickest. Most time takes less than a minute or so for that medication. Again, oral medication is usually the slowest. It has to go through the digestive system. It has to get there. Subcutaneous, it's a little bit faster, but it has to get through those layers of skin first. And then intramuscular is going to be probably about 10 to 15 minutes behind the IV medication. It's getting into the vascular system, but it's being diffused into it instead of just being straight injected into it. All right. So when the meter dose inhaler is administered to a patient, it's going to do what?
A.
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 Yep. Yeah, just like we said earlier, it's going to give that same dose every single time. Which is always great because most of the time when these people are trying to take that, they're panicking and you cram down on that real hard. It'd be really an awful system if the harder you push down, the more medication you got. All right. So you've got a 62-year-old woman. She's complaining of crushing chest pain. Her blood pressure is 84/64. Heart rate's 110. Your medical control advises you to assist her taking her nitro. After you get this order, what should you do?
B.
D.
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 B.
What do you recommend?
It would be B. For one, our protocol itself is 110 systolic, but you always want to make sure they hear you correctly. Like this says for the book itself, it's 100. So he may have heard you say 184. We don't know. Most of the time, if you're unsure about something, repeat it to them. A lot of times, it's good to sit there and say, well, your blood pressure is 84 over 54. That's 84 over 5. That way they can hear those specific numbers. And then just reconfirm the order. If they say yes, okay. Two different things you can do. You can give that. You just need to, for sure, document the name of the physician that gave you the order. That way, if anything does happen, you got a physician's order for it. At the same time, if that goes against protocols, goes against what you're supposed to be doing, then you can document as well that you did not give that patient the medication due to possibility of risk to the patient and conflicting protocols. All right, so activated charcoal is indicated for patients who have ingested certain drugs and toxins because it does what?
D.
A.
D.
D.
Yeah. Yeah, like I said, it's going in there, it's trying to absorb this medication before it can be absorbed by the body. Does anybody know what the medication is that induces vomiting?
Epcat.
That stuff sucks.
Epi-yuck.
All right. So with regards to pharmacology, the term action refers to what?
A.
I'm gonna say B.
B.
A.
So this is a good time to make sure that you're reading through the entire thing, because I know a couple of people said B.
D isn't David.
Yeah, because B is saying produce.
D.
D. That action, that's what we're wanting it to do. Remember, side effects are things you don't necessarily want it to do. Even if they do happen, that's not the intended effect. So the actions we're hoping to be produced. So which of the patients is the best candidate for oral glucose? A.
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 A. Solid A.
A.
Yeah.
A.
So while I'm sure semi-conscious is probably a fairly loose term, the main thing we have to worry about with semi-conscious patients is they may not be able to control their airway. We don't want to bank on the fact that they'll be able to swallow, give them all that gel in there, and then aspirate it because they couldn't. So they have to be at least conscious enough to follow commands. All right. Epinephrine is given to patients with anaphylactic shock because of its effects. What?
A.
A.
B.
I like A.
This one's a little tricky. Okay. You've got two that say violation and vasoconstriction. Remember, epinephrine is closing off those vessels. It's going to be B. So it's dilating the bronchioles because it's constricting those vessels again. So this one's kind of a weird one, because normally when you think of constriction, everything's closing up. With the airway, the vessels are closing up, but it's allowing the airway itself to open up. Does that make a little bit more sense?
It does now.
Remember that, yeah, I can't talk. That anaphylactic reaction is a histamine release. So epinephrine is going to be the antihistamine, and that's associated with constriction of the vessel. So the process by which medications travel through body tissues until they reach the bloodstream is called what?
D.
C.
B.
C.
C.
A.
A.
It's going to be C. Remember, they're traveling through those tissues. Traveling through the tissue itself, it's absorption. So trying to think of a good transformation. Let's see what it tells us about it. No, well, that's not very helpful at all. Absorption is what we're looking for. Whether it's absorbed through the bloodstream directly, whether it's absorbed through bloodstream due to a muscular shot, sublingual. It's being absorbed into that circulatory system somehow. All right. Look at that. We made it. And it's 7:45. We're getting done 2 hours early. Let me go ahead and stop the recording.